I think we are all in complete agreement that the current state of cancer research needs to be propelled, and there's not a better topic on emerging science in nutritional ketosis and carbohydrate restriction than what all these speakers before me have kind of really been laying out on the line. So a lot of it is standing on the shoulders of giants, of the people that have come before me, but I really want to take a second to talk about specifically breast cancer. For me, this is a more personal type of topic. 20 years ago, almost to the date, my mother was diagnosed with breast cancer. So for her 40th birthday, she actually got a breast cancer diagnosis. And when I was 8 years old, I started trying to learn all about breast cancer as I could. So that really sets us up for the talk that we're going to have today. And then we'll get in a little bit to what the KETO-CARE trial is, the phase 1 clinical trial that we're currently running here at Ohio State University. I got too clickered like everyone else did. So I feel like I would be remiss as more of a clinical oncology researcher to not at least have some sort of SEER database information for what the current landscape of breast cancer really looks like. So approximately 250,000 women were expected to be diagnosed as new cases of breast cancer in the year 2017 alone. So that number, if you take a look around at your table, it's about 1 in 8 or 1 in 6, it depends on what research you look at, women will be diagnosed with breast cancer in their life. So that's on average, one individual at each one of the tables, if they're filled with exclusively women, would be diagnosed with breast cancer. That's a number that's incredibly shocking, but at the same time, it's somewhat comforting because our diagnosis rates are getting a lot better. Our diagnostic technology is getting a lot better. And I think that we can all agree right now that the Think Pink movement has been incredibly influential in the breast cancer landscape. You look at the NFL, and every single year they have a Think Pink month, or they have a breast cancer awareness month where all the players wear pink gloves and pink shoes and everything. And that's really exciting. But what it doesn't touch on is metastatic breast cancer specifically. So I really want you to take a second and look at these last two numbers for me. So the median survival in a woman that is diagnosed initially with stage 4 breast cancer is 26.9 months. 26.9 months. And then you take that and you look at the estimated 5-year survival of a woman that's been diagnosed with stage 4 breast cancer, and it's 26% make it past 5 years. Those numbers are absolutely abysmal. The first time that my first semester when I got here working with Dr. Volek, we were writing grants. I was sitting at the kitchen table, I was pounding away, and these are like the first 3 sentences you put into any grant proposal, right? You have a prevalence rate, and you have a diagnosis rate, and a prognosis. I sat there, I typed it all out, and I had to kind of take a second, sit back, and kind of go, holy cow. Like, this is the impact of the research that we're trying to do, and this is something that is touching so many women at each time. So everyone's well aware of how much funding goes into breast cancer. You know, there's been a lot of allusions to some of the poor management of money and everything, but there's a lot of money that gets dumped into breast cancer. Approximately $15 billion has been invested in breast cancer research from the years 2000 to 2013. I think the scariest aspect of that, to me personally, is less than 7% of funding actually makes it in the metastatic landscape itself. So what's so wild to me is that these are the women that tend to be dying from the disease. And unfortunately, Dr. Champ referred to it earlier, this is not a curative-based cancer. So most of these women, when they're diagnosed, their oncologists never use the word cure with them. It's not a curative dose ever. So most of the chemotherapies, it tends to be like a 2% complete response rate. So almost never do you actually see a pure cure in stage 4 breast cancer. And that's something that kind of like hits you right in the feels, and you kind of instantly bond with women as soon as you start dealing with patients, because while you can't directly understand the struggle that they're going through, you want to be there as much as you can on an emotional level. And I think this is something that we really need to try, not just as ketogenic researchers or carbohydrate-restricted researchers, we really need to try to push the envelope in terms of metastatic specific disease. And I think all the ketogenic researchers here right now are working on advanced stage disease in some form or another, which is fantastic, but that's not happening in every other type of cancer research right now. So just a couple of quick facts to orient you with what genetically breast cancer really looks like. It depends on where you're looking at for your data, but approximately 90 to 95% of the occurrence of breast cancer is not due to heritable traits. So they're non-heritable based mutations. This is something that occurs across the lifetime of an individual. So this is normal aging. You might get mutations that occur with this. It could be an environmental factor that you've run into that has caused some sort of mutation or collection of mutations that cause a cancer or result in a cancer. And then I think importantly, BRCA1 and BRCA2, these have been highly popularized, and individuals understand when they see BRCA, they know, oh, that's a breast cancer associated gene. In reality, it's about 1 to 3% of women that are diagnosed have this heritable BRCA1, BRCA2 mutation. So it's a very small number. And then that last one, I think everyone in here, when you see this number, your face kind of lights up and you're like, oh, wow, like keto can actually get at this through this mechanism potentially. So approximately 40% of metastases have PIK3CA mutations. So that's the gene associated with PI3 kinase. I'm not going to hammer too much on that. Everyone that's gone before me has really taken a good time to explain the importance of PI3 kinase in cancer signaling as well as in ketosis. And then I think these 2 bullet points right here, everyone will look at and say, yep, ketosis might be able to hit that. So postmenopausal obesity, responsible for approximately 2-fold increase in diagnosis rate. 2-fold increase just by being postmenopausally obese. Think keto can hit that? What about insulin resistance and obesity? Those are both associated with increased mortality, nodal metastasis, so a more invasive disease, as well as larger neoplastic growth. So it is a more aggressive, it is a larger cancer, and is associated with greater death rates, all because of insulin resistance and obesity, or highly correlated with insulin resistance and obesity. So that brings us to a very similar paradigm as Dr. Scheck was just outlining. Dr. Volek, Dr. Lussberg, and myself have a paper that we published, I think, last year, kind of outlining our hypothesis on ketosis in breast cancer specifically. And so kind of what we outline is we know that we can get at metabolic changes. We've just seen that you can change the metabolism of a cancer cell by feeding a ketogenic diet or administering ketones. What we also know is that in healthy tissue, we have a vast ability to change and manipulate the metabolism of the healthy tissue as well. We know that with ketosis, there's this chronic downregulation of inflammation, so we see a massive knockdown in inflammation. We see decreases in proliferation and metastasis. A lot of this work comes from preclinical models. And I think what's really interesting is depending on what view of cancer you kind of take and what view of cancer metastasis you look at, one of the leading hypotheses right now is this concept called epithelial to mesenchymal transition. And so what that means is you have a differentiated tissue, so epithelial tissue. It gets exposed to some sort of stress or it undergoes some sort of dedifferentiation step and becomes more mesenchymal in appearance. And so that's kind of something that Dr. Scheck started to talk about, is that it becomes almost like a cancer stem-like cell. So it becomes a pluripotent-based cell that might increase its ability to extravasate and eventually intravasate into a distant organ, creating metastasis. As far as I've read, a lot of the kind of preliminary evidence on this seems to indicate that certain inflammatory cytokines are highly correlated with this epithelial to mesenchymal transition. And then lastly, some of this data gets pulled from Dr. Fine's research study. So I think one of the most important aspects of that is one small graph that he puts in there that a lot of people seem to jump over, is that sleep quality in many of these patients was improved, which is a large side effect of advanced stage cancer and as well as kind of higher dose chemotherapies. And then there was an improved emotional functioning depending on the certain qualitative scales that you actually look at. So not only are we getting at the disease, but in a group that's so used to palliative treatment, we might be improving a patient well-being at the exact same time. So if we're able to synergize a ketogenic diet with a chemotherapy or a radiation approach, as well as improve patient well-being, what it starts to look like, and this is a great analogy from Dr. Volek that I think I'll use in every talk I'll ever give, is you start looking at ketosis as just a big hammer, and everything starts looking like nails. So you just start knocking everything down, and that's exactly what's going on with the cancer treatment and kind of our hypothetical views of it right now. So all that background, sorry for rushing through it, but this is the really cool stuff. So this is the study that we're actually currently actively enrolling for and have patients undergoing, and a couple patients have already completed baseline baseline 3-month and 6-month data on this. So it's a really exciting trial. We think we're kind of fancy by coming up with a really neat acronym. And so what it is it's the ketogenic diet and chemotherapy to affect response to breast cancer treatment. Makes it this really glamorous title of the KETO-CARE study. I also want to take a second to point out we have a group of fantastic Canadian collaborators sitting right up here in the front. Dr. Jerry Crystal, Dr. Dave Harper, and then Dr. Ingrid Elysia. There are fantastic collaborators that have been instrumental in our ability to really gain a significant amount of funding for this research project. So what our study is it is a control trial with 20 patients in each arm. So we have a control arm that's undergoing standard of care nutrition advice, and then we have a ketogenic arm as well. I do want to take note that it is not a randomized design. We are using a self-selection criteria. We don't think that it's necessarily the most ethical thing or the easiest choice for an individual to get randomized into a ketogenic diet, especially if there's someone that already naturally follows something like an Ornish diet. So it'd be very difficult for them to go into a keto arm. So with that, we realized that we might be sacrificing some of the pure RCT, wonderful facade that most people tend to get at. But we think we're going to see some really cool results with this as well. What's really cool about this study, and I hope you guys agree, is that the first 3 months of the trial is a controlled feeding study. So we actually have a kitchen here on campus where we cook and prepare 100% of the calories that these individuals are supposed to be eating. Because it's such an important study, we're actually customizing the menu to every single patient that's enrolled in the trial. So if they want fish one day, they get fish. If they want filet mignon, we've served filet mignon. A lot of this is headed up, if you look in the back, all the way in the back line, this is the rest of the Volek team, and they're with me, they're in the kitchen, in the trenches, preparing all the food for these patients on a daily basis. So, cool, controlled feeding study. What does it mean in real life? So that's the second half of our study. The second half is really looking at a free living experiment. So if we can get women into ketosis, fantastic. How do they do when they're walking around the grocery store on their own? Are they able to buy groceries? Are they able to skate the peripheries and actually do this on their own, formulate their own diet based on the way that we've kind of educated them? And when you kind of zoom out to 30,000 foot, essentially we're running 2 studies in one study. The first 3 months, is there a biological effect of nutritional ketosis in advanced stage cancer patients? Is there a biological effect? The second, is it feasible? If it's not, if there's no biological effect, what does it matter if it's feasible? No one's going to do it, right? If it's feasible, but there's no biological effect, why do we care? The next couple of slides, we're going to talk about some of the baseline and 3-month PET-CT data that we've seen with some of these patients. But I also want to note that we're doing some of the most comprehensive immunophenotyping that's ever been done in this specific population, especially surrounding ketosis and the potential ways that ketosis might augment kind of the immune system of the body. So we're actually taking and doing both an innate and adaptive immune challenge using E. coli and herpes simplex virus. A lot of that work is being spearheaded by our Canadian collaborators, as well as Ryan Dickerson, who's walking around somewhere. He's one of the biochemists on our team. So I think you guys are well enough teased that you want to see some data, yeah? I got double clickered again. Okay, so we're going to look at a couple of patients. That's 3 months data. It's only the keto arm, so I'm not going to show you comparative controls. I just want to really hit some of the highlights, right? So, okay, cool. It's like mixed up on the screen. So what we have here is we have a 43-year-old African-American woman. She was actually presented with stage 4 breast cancer on diagnosis. She did 1 round of chemotherapy, or 1 single dose of chemotherapy at another cancer center in Chicago. Came here because she didn't like the way she was treated, and now she's undergoing treatment at James, or at Stephanie Spielman, if you will. She was ER/PR positive, HER2 negative. So for those of you who are unfamiliar with breast cancer research, a breast cancer is not a breast cancer is not a breast cancer. It is one of the most heterogeneous cancers that is out there. And so we tend to grade people and rank people in their treatment-based strategies on their histochemistry. So that means it's estrogen receptor positive, progesterone receptor positive, and HER2 negative. So generally, there's a very specific treatment strategy that's associated with this. She happened to have metastasis specifically to the liver and the bone, and she was undergoing a taxane-based therapy. She was using paclitaxel, which she was on 3 weeks on, 1 week off. So just to kind of give you a view of what she was like as a woman as well. On the top, we're seeing baseline PET-CT imaging. Dr. Fine did a fantastic job. I don't want to go back over what PET-CT imaging really looks like, but just to give you an idea, what we're looking at is how black are these images. The blacker this image is, the more metabolic activity, the more active the cancer is. So if you look, you see cardiac tissue right here, kidney, ureter, bladder, as Dr. Fine said, that's all completely normal. You also see the brains lighten up pretty good. It's expected. We've been here for the past 2 days. These are actually metastasis specific to the liver. So this is a very large metastasis, very large lesion, and then most of this right through here is lesion. It gets a little convoluted because the kidney is sitting right behind there, so you're kind of picking up a little bit of the kidney as well. And this is a more focused view. If you look, she already has necrotic cores, so there might have been a miniature effective treatment or a small effective treatment going on when we imaged her, and that's kind of what you're seeing right here. So you see a dark and then a bit lighter in the middle. And what I want you really to pay attention to is the 3-month data. So I don't have any of the SUVs up here. That way we can actually report the true data whenever we publish the paper. But I don't think anyone in here would argue that that is significantly less black, right? So that's 3 months of ketogenic diet treatment plus 3 months of Taxol-based therapy. So this response is not completely out of the ordinary, but this was actually our first patient, and so I sent Miriam a text, and I was like, how excited should we be about this? And she's like, yeah, you guys should be pretty excited. So you guys can all be excited right now, too. Okay. So this is actually a 3-dimensional rendering of that exact same image that I was just giving you. So as you see, it'll rotate around, and you can kind of see that that kidney is whenever you get the full frontal view, it's kind of making it look a little bit worse. The green arrow is pointing to residual port activity, so there's a little bit of dose still in the port when we infuse the dose. All the blue is pointing to those liver-based lesions. And something that we all thought was really cool that made us have like a holy crap moment was the heart is there at baseline. We no longer have heart. And that's something that we've seen in every single imaging at 3 months since. So the heart completely drops off, so we're using almost exclusively ketones and non-esterified fatty acids is what we tend to be thinking. So we're moving forward in discovery specifically on cardiac metabolism as well. So also, this was done with average ketones of 0.6 and average blood glucose of 90. So it was not an extremely restrictive ketogenic diet, but she was well within the range of nutritional ketosis. Next 2 slides get a little bit crazy. So what this is this is dynamic imaging. So we are basically able to create a flip book of PET-CT imaging across the first 15 minutes. So we create a movie file. This is just a screenshot of the next slide, and you can see it's one of the busiest figures I've ever tried to present in my entire life. So there is an orange circle right here that kind of masks and mirrors this orange lesion, which is one of those primary liver lesions we just saw, and the blue is doing the same thing. Over here, you're going to see a kind of change in perfusion of the cancer, and then some of the healthy tissue, the dose will drop off, and you'll see the lesions continue to grow. Told you it's a really busy slide. So wait for a couple of seconds. When it hits 15 minutes, right back here on this bottom corner. So boom, it goes down the descending order. The liver fills, the liver's perfusing, it's going back out, and you can slowly start to see that each one of these tumors is starting to take on quite a bit more FDG. So they're still highly metabolically active as compared to the rest of the background, which is not as metabolically active. So it's really testing perfusion, and what we're going to do eventually is calculate the exact metabolic rate of the cancer at that time. And then this is quite important of a slide. I think everyone that just looked at it went, whoa. So this was one of our patients. You can see she had quite a bit of liver lesions at the start of the diet. This is a patient that has been on chemotherapy and been on several types of drugs prior to this with a stage 4 diagnosis. Hadn't really seen any great improvements. At 3 months following ketogenic diet and her Xylota, which is like a capecitabine, it's a precursor to 5-FU. Try to find the black. right? Just for everyone, the radiology report said that there is minimal detectable difference between the previous lesion sites in any sort of background parenchyma. So it's almost impossible to distinguish what the cancer has done in the liver. There's still a couple of hypermetabolic sites on the bone at this time. Average ketone, 0.53, so just over the nutritional ketosis line. Average blood glucose of about 105. I know I ran over. Last slide. So this is a testimonial from that previous patient. So I want everyone to take a second, read this, read it really well, and then we can have a discussion during this roundtable with all the rest of the speakers about how important this is, not just from a physiological standpoint, but from an emotional standpoint at the same time. For anyone that's been around someone going through chemotherapy or radiation, it is a very passive experience. Everyone, you kind of go in, you have an IV, you get the drug pushed, or you have radiation therapy administered. Whenever you're actually sitting there able to physically do something yourself that you can buy into and feel that you have an objective biomarker looking at, such as ketones, it really helps kind of reinforce why you're doing it, and the patients really buy in. They really love it. And I think these last two sentences, my most recent scan shows that my liver mets have regressed and are almost undetectable. I've lost 20 pounds without trying. I'm off sugar without any cravings, and I never thought that would happen. Fantastic. Absolutely fantastic. And then I want to thank the rest of our team here. So Mr. GQ, Dr. Jeff Volek right now. The rest of the Volek team, and then our Vancouver collaborators, and then Dr. Knopp, Dr. Wright, and Katie Benzel, they're all part of the imaging team here. And then I think we can all agree we can't thank Miriam Musberg enough. She's been absolutely pivotal in our ability to get in and interact specifically with patients here, and she's kind of been the one that I think has taken a lot of arrows for us at Ohio State, because not once has anyone ever told us we're crazy to our face. So with that, thank you.